Next is V11 diaphragmatic rupture. You are called to see 25-year-old patient injured in a T-bone collision, suspected of having a splenic injury. Diagnosed on ultrasound fast. Her chest X-ray is as follows. What's your suspected diagnosis? Splenic injury, so traumatic diaphragmatic rupture. What additional investigation would you consider, assuming the patient is mechanically stable? So for traumatic diaphragmatic rupture, the X-rays may be normal, or the signs of diaphragmatic rupture of chest may be lung injury, including pleural effusion, atelectasis, pulmonary contusion. Non-specific diaphragmatic elevation should alert the team to the possibility of diaphragmatic injury. If the patient is stable enough for trauma, pan-CT scan, CT signs of the diaphragmatic rupture include discontinuity of the diaphragm, visceral herniation, and waist-like constriction on the viscera called the collar sign. So what are the common mechanisms of injury for the diaphragm? So diaphragm can be ruptured in both blunt and the penetrating trauma. Most blunt diaphragmatic rupture result from the motor vehicle crashes, likely due to the pressure gradient between the pleural and the peritoneal cavities when seatbelt restraint passengers are involved in the collisions. Left-sided ruptures are common than the right, but due to the relative protection of the lever, it takes more energy to rupture the diaphragm on the right side. Hence, right-sided injuries are associated with a higher mortality. Lateral impact from a T-bone collision is more likely than any other type of impact to cause a rupture, since it can distort the chest wall and shear the ipsilateral diaphragm. Front impact from a motor vehicle crash can cause an increase in the intra-abdominal pressure, which results in long radial tears in the posterolateral aspect of the diaphragm, its embryological weak point. Blunt trauma typically produces large radial tears. How do you treat diaphragmatic injuries? So diaphragmatic injuries are usually associated with lung contusion, rib fracture, splenic injury. So due to the association of abdominal injuries in acute setting that requires surgical intervention, the abdominal approach is more common. Although thoracic approach is appropriate for patients where the injury pattern requires thoracotomy and no laparotomy. Regardless of the operative approach for repair of the traumatic diaphragm hernia, the two main principles of repair are complete reduction of the herniated contents back to the abdominal cavity, and number two, complete closure of diaphragmatic defect by direct suture with interrupted or running sutures with non-removable sutures. Even small ruptures should be surgically repaired because they don't spontaneously heal, and then later on herniation can happen. Post-repair, patient should have a chest tube on the side of the repair for optimization of the respiratory function. In case of post-operative bleeding from both from the repair site as well as from the associated injuries. Thank you.